As we all know, the US is just stepping into the much anticipated time frame where the baby boomers are aging. The US Census Bureau is projecting that by 2030 is going to be a milestone year where the older adults in the US will outnumber the children for the first time in US history. Ted, how do you see this growing Medicare population impacting the healthcare? Obviously, it's going to be a large impact, but maybe you can break it down for us a little bit.
Obviously, as a longtime activist for individuals with disabilities, that includes obviously the largest cohort of individuals with disabilities are our senior citizens who face mobility, hearing, vision, other types of impairments and conditions. We need to be smart about how we deliver healthcare now. And we're seeing much more home based models, extending care models into the home, which is where people want to live. And it happens to be the cheapest place to provide care as well. So I'm very excited. You know, who would have thought that house calls from doctors that we all had when we were children would now be back and the most cost effective way to deliver healthcare? So we're also getting back to the prior comments about what is cost effective. It turns out that if you deliver hot meals to a senior citizen in their home, you're actually going to reduce their healthcare consumption and keep them out of a more costly healthcare setting. So we need to be creative and look at healthcare provision in a more holistic way.
Ted, that's a great example. And it does go back to the nature of the system that Lynn was telling us about. The fact that CMS is putting Medicare Advantage plans at risk and giving them funds, though, to do the innovations of the type that you just described, that's yielding real benefits to patients, to consumers, to Medicare beneficiaries. Question I would have is, can we get the self-funded plans to do likewise, to put some money on the table that give the providers incentives to create new care paths, new service delivery models of the type that you outline, and see what they bring to the advantage of their employees?
I would also add that our definition of health law is expanding because of social determinants of health. We're seeing IPAs that are not just doctors and clin labs and hospitals and ambulance companies, but it's also plumbers and carpenters and transportation companies and food service who are pivoting to provide those services to an industry that they're not sure what healthcare is. And our job as health lawyers is to help them navigate their new participation in what is a plus 50-year health regulatory scheme that they're not familiar with. And so the sooner and quicker we can bring in the providers of social determinants of health into the healthcare ecosystem, the sooner they can provide the goods and services that the payer and patient community are looking for in order to be more efficient and to have a better lifestyle, particularly for those people who are aging in place in their homes. We cannot afford to have everyone in nursing homes who are aging, and we really need to maximize that's where people want to be anyway, but we need to figure out better, quicker, how to help people age in place.
So when I think about it, I think about, you know, the 80-20 rule that could be applied to many, many examples in our economic life. That is, you know, 80% of the money in healthcare goes to less than 20% of plan participants. So, Mark, you talked about, can we get self-funded plans to make these same investments in value-based care as we're seeing in the Medicare program? But we know that that's not likely to happen if people are jumping around from job to job, from plan to plan. So one employer may make these investments and not recoup the benefit until many years down the line when that person may no longer be employed. So I think a lot of this innovation may take place in, for example, the labor union marketplace, or in these large states that have these retirees that are on the hook for paying for people's long-term care, that's where I think a lot of this innovation is going to take place.
And Lynn, as you mentioned, all of this is connected through data, right? So Ted, I completely agree and appreciate what you're saying, that healthcare is not just going to be doctors providing patients with care in a hospital. That's not what it's going to be anymore. It's expanding. It's car share rides. It's everything. It's grocery stores. And I think data is what's going to connect everybody. There's been a recent focus in U.S. policy to provide all the stakeholders in the entire healthcare ecosystem. And as again, we mentioned, this is really an expanding ecosystem with increased access to patient data. And the driving force behind that has been to, number one, empower patients to make more informed healthcare, and number two, to provide clinicians and other stakeholders with access to comprehensive information about an individual to both improve care coordination and ultimately improve the. Some are saying, data is the new oil in the digital economy. And, we have EMRs over the past couple decades. We have health and fitness apps on your mobile devices. And we also have wearable devices. There's so much data out there. Mark, how do you see all of this increased focus on healthcare data, and how can it impact the next decade in healthcare? There's a lot of data. Somebody has to control it, regulate it, find a way to really harness it.
You raise a super interesting question. I do think data will help consumers shop more knowledgeably, arm them with better questions, but I think it does have its limits. That in healthcare, treatment choices are dependent on multiple variables and symptoms and what the feasible alternatives be. Much of those are going to remain in a situation where the consumer really needs an informed clinician's guidance to make those choices. While there has been a theme that price transparency will lead to sufficient shopping by consumers that might constrain prices, even despite my antitrust training and experience, I'm relatively cautious in adopting that view, because while there may be some services that are sufficiently a shoppable service from consumers' perspective, many more aspects of treatment of chronic conditions are more nuanced and not susceptible to sort of commodity based shopping. In fact, I saw a paper by the Congressional Budget Office last week, which predicted that the transparency initiatives would only move the healthcare spending needle maybe a point or so. So it didn't put a lot of hope in that alone being the antidote to efficient spending. Now, there is one place where I think data is underappreciated, and I think Lynn alluded to it earlier, and that is that the data we now have as to patient conditions, beneficiary conditions, that feeds into risk adjustment being done by CMS, Medicaid programs, and some other programs, has given us the tools that we need to fairly share risk with provider groups and give the provider groups the financial incentives they need to help us make those very difficult decisions as to the most efficient care path for any condition presented.
Well, I think that data, this massive amount of unstructured data that is out there, is going to be complicated to try to make use of. I mean, think of the multi-billion-dollar companies and attempts to devote hundreds of the smartest people to try to figure out where are the nuggets of information in this data. But when I think, and again, I'm speaking to you is my experience perhaps as a former state legislator in Connecticut. When I think about data and how our society can better use data, I think there are some long-term goals for which it's going to be very difficult to try to make sense of all this unstructured data. But there's some immediate benefits. For example, we know through many analyses that the hospital that you end up going to, for example, for chest pain, can vary by tens of thousands of dollars. So that's an area where I think better data can help people become much more cost effective and smarter consumers.